Now, this is the basic structure of a primary motor cortex. The primary motor cortex lies in the precentral gyrus structure of the frontal lobe. It relays commands for the skeletal muscles to operate in an effective and effective manner to control various voluntary muscles. Now, the primary motor cortex, it relays several tracts, corticospinal tract or corticobulbar tract, and through midbrain, medulla, and spinal cord, it traverses the commands through anterior horn cells to the either to the cranial nerves or to the spinal and peripheral nerves, which later direct the skeletal muscle to perform a specific function. And this is a normal structure. Now, what happens when it is affected by motor neuron disease? The muscle gets atrophied due to the affection of this nerve by motor neuron disease. Now, as this corticospinal tract is there and it relays the information through the spinal nerve, similarly, there is corticobulbar tract which relays the information through 9th, 10th, 11th, and 12th cranial nerves.
Namaste and a very warm welcome to everyone joining us today. I, Dr. Karishma Singh, firstly would like to thank the organizers for giving me this opportunity to introduce today's guest speaker. Thank you, Dr. Rajkala ma'am and the team. It indeed is a privilege to be part of this platform that brings together scholars, clinicians, researchers to explore the scientific dimensions of Ayurveda. I welcome you all to another enriching session of online guest lecture series on evidence-based Panchakarma. Today's lecture promises to be truly enlightening as we explore a crucial and challenging area of concern, that is motor neuron disease, through the lens of Panchakarma. As we know, MNDs are progressive neurodegenerative disorders with limited treatment options in conventional system of medicines. However, Ayurveda, through its holistic and individualistic approach, provides promising possibilities that we aim to understand better today. And to guide us through the subject, we are honored to have Dr. Adil Rais, sir, an accomplished scholar, clinician, and a researcher in the field of Panchakarma. Dr. Adil sir completed his MD in Panchakarma from NIA Jaipur and earned his Ph.D. from ITRA Jamnagar, which is now ITRA. He is currently serving as an Ayurveda Medical Officer under Government of Uttar Pradesh with his present posting in Sultanpur. In his previous roles, Dr. Rais has served as Panchakarma Specialist at Lok Bandhu Rajnarayan Combined Hospital, Lucknow, Assistant Professor in Panchakarma at Bharat Ayurveda Medical College, Muzaffarnagar, UP, and CDL College of Ayurveda, Jamnagar, Haryana. His specialization in this field and his diverse experience across clinical, academic, and research domains make him uniquely qualified to speak on today's topic. I now invite Dr. Adil sir to kindly take over the session and share his valuable knowledge with us. Dhanyavad, and over to you, sir.
Thank you, Dr. Karishma, for these overwhelming words. Thank you, ma'am, for giving me this opportunity to conduct a lecture, to present myself on motor neuron diseases and their management through Panchakarma. It's a wonderful platform of propagation of knowledge. I thank all of you. I thank especially Rajkala ma'am to give me this wonderful opportunity. Thank you. And I'd like to start my presentation, which is motor neuron diseases and their management through Panchakarma. Now, we have divided this presentation into four prominent divisions. First of all, we'd like to take a proper understanding of the disease and the involved structures, mostly the upper motor neurons and the lower motor neurons. Then the management options provided by through Panchakarma, and then the research work which was conducted by me and under the guidanceship of late Professor Radheshyam Sharma sir at the Department of Panchakarma, NIA Jaipur. So that was my postgraduate work. And finally, we would like to post some recommendations for the future studies to tackle this dreadful and deadly disease, actually. Introduction to MND. Motor neuron diseases is characterized by steady, relentless, progressive degeneration of the corticospinal tracts, anterior horn cells, bulbar motor nuclei, or all of them combined. So we'd like to go step by step and understanding these particular structures, because to understand the disease and to understand the symptoms, it is very important to understand these individuals' structures and their roles in the disease. So this motor neuron disease encompasses the disorders that exclusively affect upper or lower motor neurons or both. It involves central nervous system as well as the peripheral nervous system. Now, this motor neuron disease, it can be acquired and it can also be inherited through familial heredity. Now, this is the basic structure of a primary motor cortex. The primary motor cortex lies in the precentral gyrus structure of the frontal lobe. It relays commands for the skeletal muscles to operate in an effective and effective manner to control various voluntary muscles. Now, the primary motor cortex, it relays several tracts, corticospinal tract or corticobulbar tract, and through midbrain, medulla, and spinal cord, it traverses the commands through anterior horn cells to the either to the cranial nerves or to the spinal and peripheral nerves, which later direct the skeletal muscle to perform a specific function. Now here, it is important to understand that what are upper motor neurons and what are lower motor neurons. Any neurons, any motor neurons which perform the motor function, which give command, which help in relaying the information, if they are lying in the central nervous system, they are known as the upper motor neurons. And the motor neurons which are lying outside the central nervous system, they are known as the lower motor neurons. So this basic understanding is very important to understand the basic nature of the disease and basic clinical features of the disease, because this disease is actually diagnosed on the basis of clinical features only. It is not, there are no specific diagnostic tools. The only diagnostic tools are used to make differential diagnosis or exclude other diagnosis and confirm the diagnosis of motor neuron diseases. Here in this diagram, we can see the precentral gyrus. It relays the corticospinal tract to the and at the pyramids lying in the medulla, there is decussation of fibers, and these fibers, they divide into lateral corticospinal tract and anterior or ventral corticospinal tract. Now the lateral corticospinal tract, it traverses through and reaches the gray area of the spinal cord where the anterior horn cells are lying, and through these anterior horn cells, spinal nerves or peripheral nerves, they reach the distal or proximal muscles and direct them to do a specific function or act in a specific manner. In the second figure, we can see the normal neuron and a diseased neuron, the neuron which is affected by the motor neuron disease. Now, a normal neuron, it is attached to the normal muscle, and this is a normal structure. Now, what happens when it is affected by motor neuron disease? The muscle gets atrophied due to the affection of this nerve by motor neuron disease. Now, as this corticospinal tract is there and it relays the information through the spinal nerve, similarly, there is corticobulbar tract which relays the information through 9th, 10th, 11th, and 12th cranial nerves. Now, coming to the anterior horn cells, these are the basic structures, and these are the first structures of a lower motor neuron from which the information is relayed or the command is relayed to the skeletal muscle. These are large lower motor neurons lying in the anterior horns of the spinal cord. These send long axonal processes via anterior roots or the ventral roots to peripheral skeletal muscles. Now, their degeneration, it leads to denervation of muscles. We can see what we can see in the patients is weakness or atrophied muscles, or emaciation is present. On the basis of inheritance or acquired, the types of MND has been divided into inherited or acquired types of variants. Now, basically, when MND is classified, it is mostly classified as UMN, LMN, or both on the basis of the features. Now, here, first classification is through the inherited or acquired variety. Now, inherited variety consists of spastic paraparesis, spinal muscular atrophy, and ALS, that is amyotrophic lateral sclerosis. The acquired variety of MND, the first one is infectious, which is very common, which was very common earlier and is referred by the name poliomyelitis. The second one is motor neuropathy, and the most common type is sporadic ALS or irregular type of ALS, which is not inherited or non-familial. The inherited or the familial variant of ALS is generally varies from 5 to 10%. The rest of the variant of the ALS is sporadic. There are certain genes which are involved in the in motor neuron disease and in the inherited variety especially. So these genes are SOD1 and SMN1, which are related with ALS or spinomuscular atrophy. This is only responsible for 8 to 10% of the amyotrophic lateral sclerosis. Rest of the types are not genetic. Now coming to the amyotrophic lateral sclerosis. As through the name, we can understand that there is amyotrophy. Amyotrophy means loss of nutrition or loss of structure of the muscle. And since the lateral horn cells are involved, so it is the word is lateral here. And sclerosis means there is hardening of the neuron. So this is the most common type of motor neuron disease. It is also known as Lou Gehrig disease, Charcot's disease, because these were prominent figures. Lou Gehrig was a baseball player. Charcot was a French scientist. And recently we have heard about Stephen Hawking, who is known for his popular theory of black holes. So they were all suffering from ALS. Now the 5 to 10%, as I've already told, it is inherited. The rest is sporadic. Now there are UMN signs and LMN signs in ALS. Human signs consists of stiffness. It is due to spasticity. Now we'll, as these slides progress, we'll understand what is spasticity and all the other relevant terms. So clumsiness and stiffness is due to spasticity. Then hyperactive deep tendon reflexes are there, and Babinski sign is present. In the element dysfunction, weakness and wasting are present, plus abnormal twitching of muscles, which are known as fasciculations, it is present, and the reflexes are silent or absent. Now coming to two other variants of UMN motor neuron disease, they are bulbar palsy and a very similar type of palsy is pseudobulbar palsy. Now we should know to differentiate between the two. Basically, bulb means a structure, or it commonly refers to medulla. So the origin medulla is this bulb. There is a structure called nucleus ambiguous. Now this nucleus ambiguous is the origin site for 9th, 10th and 11th cranial nerves, that is glossopharyngeal, vagus and spinal accessory cranial nerves. The hypoglossal nucleus in the bulbar region, it is site of the origin for the 12th or the hypoglossal nerve. Now affection of this leads to bulbar palsy. Now bulbar, although it is located in the medulla region, but nucleus, up to the nucleus, any tract, or as I have already earlier mentioned, the corticobulbar tract travels from the primary motor cortex of the frontal lobe and it traverses up to the bulb. So that particular region, now the cortex and the corticobulbar tract, they constitute the upper motor neuron. Anything distal to that will be constituted under the lower motor neuron. So that is why bulbar palsy is considered as a lower motor neuron dysfunction. The prominent clinical features which are present due to bulbar palsy are dysphagia, that is difficulty in swallowing, because of the paralysis of or affection of soft palate, tongue and pharynx. Now, dysarthria, there's difficulty in articulation of speech. Now speech, as we know, speech is produced from the larynx, and various sounds are produced by the movement of the tongue. Now there is difficulty in articulation due to affection of these particular regions, that is termed as dysarthria. The fasciculations, as I've already mentioned, fasciculations are twitching of muscles with involuntary twitching of muscles with large amplitude and large potential. Then there is another important feature of bulbar palsy, which is nasal regurgitation of fluids. Now why nasal regurgitation of fluids happens? Because the soft palate and the pharynx, they all have become weak. They all have become paralyzed, or somewhat paralysis is there due to affection of the 9th and 10th nerves. So what happens, whatever fluid the patient is taking, it comes out through the nasopharynx and it is regurgitated back. So that is nasal regurgitation of fluids. Now, very similar to bulbar palsy is pseudobulbar palsy. Now, what happens in pseudobulbar palsy? The point of affection is different. The point of affection is higher. It is the corticobulbar tract. So the pseudobulbar palsy results from the UMN affection, involvement of corticospinal or corticobulbar tracts. Now, since the involvement of corticospinal and the corticobulbar tracts are there, so the cranial nerves which are chiefly affected are fifth, seventh, the motor part of this, not the sensory part. Never in motor neuron disease, sensory part is affected. We'll read that about that also later. Then the 9th, 10th, and the 11th and the 12th. These from the corticobulbar portion and corticospinal, 5th and 7th nerves. The prominent clinical features are spasticity of tongue and spastic dysarthria. These features are closely related to dysarthria and dysphagia. But there is one feature through which we can clearly distinguish between the bulbar palsy and pseudobulbar palsy, and that feature is emotional lability or emotional incontinence. Now, what happens? There are times when we see in a patient that it's not a matter of laughter or it's not a matter of crying, but automatically the patient starts to laugh or automatically the patient starts to cry involuntarily. That is emotional continence. That is the mood is not presented correctly. You can say that the mood of the patient is not presented correctly because of the involuntary laughter and involuntary crying. That is a very prominent and distinguishing feature present in the pseudobulbar palsy, through which we can differentiate it from the bulbar palsy. Now, to understand the things better, the clinical features present in the UMN dysfunction are spasticity. Now, what is spasticity? Spasticity is actually when any movement in the initial phase and in the final phase, there are hindrance or an obstruction. Then, like 10 to 15% of the initial phase of the movement. For example, if we consider the flexion of elbow, so this movement here, in starting the movement, there is difficulty, and in ending the movement, there is hindrance or obstruction. It takes more time than the rest of the movement. So what happens? This is known as spasticity. We sometimes refer it to as clasp knife spasticity. So then the slowed, rapid alternating movements. Generally, if we see this movement at alternating movements at pronation and supination, and this is pretty rapid. Now, this if UMN dysfunction is there, this movement will be slowed. It will not be that rapid. Then the tendon reflexes in the UMN dysfunction, they will always be the deep tendon reflexes will be hyperactive. Then dysphagia and dysarthria will be present. It will be obviously spastic type. Then emotional lability, as I have explained earlier, it is the incontinence of the emotions, crying or laughing. Then frontal release signs. These are the signs which actually are present in newborn babies, like the sucking reflex or the Babinski sign of the greater toe. These reflexes actually automatically disappear after some time, but in UMN dysfunction, these signs, they reappear. So Babinski signs is positive in this particular UMN dysfunction. Now, to get a better understanding, I have added some video clips through which we can understand the features in a better way. This also has a purpose, which I'll come across over to this. Now you can see here the patient is speaking something, and he has to put extra force for that speaking. This is dysarthria. Articulation of words is not proper. People are not able to understand what he is speaking. It takes time. The speech is slow, and the speech is, the articulation is, the joining of the words is, it is delayed.
दूसरे वाले डॉक्टर ने
So this is the dysarthric speech actually. Moving on. Next is the element dysfunction, which is represented by clinical features like weakness and muscle wasting. Fasciculations are present and hyporeflexia or areflexia are present. Now I have added certain video clips just to understand these features in a better way. Like here we are showing a patient of muscle wasting and weakness. You can see the distal and the proximal muscles all are affected, and there's severe atrophy of muscles. Here. The muscles of the forearm, arm, the hand. Now what happens is these there's very little movement, only flickering type of movement is there. You can see that. And when the muscles become weak, what happens is the gait also becomes weak. And this was a patient in which we are showing the gait of the patient, and this is due to the element features present in the patient. Muscular weakness. He is not able to walk. He has to drag his feet. He has to. Now you can see the gait, and how can we distinguish from the hemiplegic gait? Now this gait is bilateral. It is not unilateral. So we can easily differentiate it from the hemiplegic gait. Although in the MND also the distal muscles are affected, so proximal muscles, the patient tends to move the more effort, lay more effort on the proximal muscles. You can see it here. It is very clearly understandable. Next, there are two types of onset of motor neuron disease which we need to know. First, the more common type is the limb onset. Limb onset, what happens in limb onset is that distal muscles of hand and feet, they are affected first, and their atrophy is present, and small or finer movements like writing, like closing and opening of buttons, like brushing our teeth, like shaving, they tend to lose, there's a loss of activity, or there's an affection of these activities. And you see this patient is trying to tell me that he is not able to unbutton and button his shirt due to the loss of or weakness of the distal muscles. He takes some extra time in opening the button. These are the first features which are present. Now these are the tongue fasciculation. They are found in the second type of onset, which is the bulbar onset, bulbar or pseudo-bulbar onset. Now you can see the wriggling or the twitching or the involuntary movements which are present in the tongue. So this is a feature of bulbar onset of ALS. Yes. So we can see here there is some involuntary movement of the tongue. But here again we can see the dysarthria. There is a nasal component involved in dysarthria. Whenever there is a nasal component, we can understand that bilateral affection is there. So these are two different types of onset: limb onset and bulbar onset. Next, coming to the differential diagnosis. Now, the differential diagnosis of motor neuron disease is generally very clear, but there are certain conditions which mimic motor neuron disease. Most important is the neuropathies and the radiculopathies due to cervical spondylitis. Now, sometimes what happens that due to overlapping features, we need to take this thing in consideration, that never ever in motor neuron disease will the sensory nerves be affected. Never. Sensory nerves never gets affected in motor neuron disease. If sensory nerves get affected, it is not a motor neuron disease. That is a very clear thing. Everyone should just make this thing very clear. For the diagnosis of motor neuron disease, sensory is always absent. Then considering the myopathy. Now, there's always a difference in myopathy and neuropathy. Neuropathy, it always it starts from distal muscles. This is the property that neuropathy always starts from the distal muscles, and myopathy patient, the disease will always start from the proximal muscles. Now, for example, if a patient is of myopathy, for example, muscular dystrophy or myasthenia gravis, he will always tell you that whenever I try to lift a weight or whenever I try to put a suitcase over somewhere, then there's a difficulty. I face difficulty. So that is due to the affection of the proximal muscles. And the in the motor neuron disease, we always see neuropathy. That is, the distal muscles are affected first. Like those I've shown you the video that buttoning of the shirts is present. One other disease is there, that is inclusion body myositis. Now it is an inflammatory condition always accompanied with pain. An inflammatory condition always accompanied with pain. So pain in most of the cases of motor neuron disease is not present, or if present, it won't be a matter of concern because it won't hamper their daily activities. So what happens is these are the differential diagnosis, which if it is not clear, then we can go for some diagnostic tests. But still, the diagnosis of motor neuron disease is almost always clinical. It is never ever these particular diagnostic tests are used generally, but just to overrule or to exclude the cervical spondylitis or cervical radiculopathy or any other. For example, EMG can be used, but the clinical features are very, very evident. So most of the time, we don't need to go to these tests. Symptom, what I was mentioning earlier was this, that symptoms which are always spared in motor neuron disease. First one is the sensory deficit. Then there's patient is almost always conscious. He knows what is happening, or orientation is very good. The bowel bladder activity is never affected. Bowel bladder abnormality is not present in the motor neuron disease because it is differently supplied by the pudendal nerve. Now the eyeball movements are also always spared from the motor neuron disease affection, because what happens is that the cranial nerves which are responsible for the eyeball movement, the third and the fourth and the sixth cranial nerves, their nucleus is directly present in the cortex. So there is no nucleus, or the cranial nerves are not in the subcortical regions or in any other regions. So what happens is eyeball movements is always preserved in the motor neuron disease. Sexual dysfunction never happens in the motor neuron disease. The prognosis, coming to the prognosis of the disease, the prognosis of the motor neuron disease is not very good. It is, we can call it poor actually, because it is a progressive disease. What happens in a progressive disease? It starts from distal muscles. It's first and foremost the distal muscles are affected, and then the disease progresses proximally. Now what happens after the progression of the disease? Slow and steady progression. Gradually the muscles which are important for life, they get affected. For example, the respiratory muscles or the muscles of the diaphragm. So then the patient starts having difficulty in breathing. And then the patient, for the patient, it is very difficult to cough out things. For example, patient is not able to proper cuff. He has to make extra effort for coughing, but he's not able to do proper coughing. So that is a very big reason that patient suffers from respiratory infections very fast. So lifespan of ALS is generally 3 to 5 years. That is a very dreadful condition actually. So the prognosis is not very good. Now, in the modern medical science, there's only one treatment option which is available, and that is riluzole. It is a medicine which is said to be anti-glutamatergic, and it inhibits the NMDA receptors. The only action for which riluzole is given, and it is known, is that it extends the life of the patient for 180 days on usage of 5 years. That is the only action of riluzole. No effect on the quality of life, and that is where we can have our role or our presence felt. Now, coming to the Ayurvedic perspective for motor neuron disease can be correlated to Vat Vyadhi with the main vitiation of the Vayu dosh. There are symptoms according to Sushrut like Vak Parushyam, which can be correlated with dysarthria. Karsha is there. Karsha means wasting of muscles, and Karshne Gatra Spuran we can correlate it to fasciculations or abnormal twitching of muscles. Ocean Kamita, Nidra Nash can be present in patients. Alp Bal is present. Now, Alp Bal means loss of strength due to loss of the muscle mass. The normal function of Prana, Dhyan and Udan Vayus, it is also deeply impacted. Vishwas, Nishwas, and the Prayatn Karm, Urja, Balvana, Adi Karamcha of the Udan Vayu, they are deeply impacted in the motor neuron disease. However, in motor neuron disease, along with Vat Prakop, there appears a variation of Kaph dosh also, which indicates mostly an Avaran-janya pathogenesis can be thought of here. So besides mass balashaya, which is the most predominant feature in motor neuron disease, it leads to death. It can also be related to Ojakshaya. Now, a combination of Avaran can be imposed in the pathology of motor neuron disease. The Kapha Avrit Pran, the symptoms like Shivan, Shaftud, Gash, Shwas, Uchwas, Sangra, these can be thought of the last symptoms, last clinical features when the respiratory system gets involved. Kapha Avrit Udan, where the features can mimic the, we can correlate it to the dysarthria or the dysphagia type of features. Vavarne, Vaksvagra, Dorbalyam, Guru Gatraktvam. Now the Kapha Avrit Vyan, this in here the features like Guruta, Sarv Gatranam, they can be correlated with the motor neuron disease. Then in the conditions of Pitta Avrit Udan, there is Ojo Branch, which is generally found in every patient of motor neuron disease. Anyonya Avran can also be taken into consideration because Karm, Ojo, Balvana, Nasho, Mrityu, Rathapi, in wherein the Udan Vayu covers the Pran Vayu, they resemble the features of, and in this also there is mentioned that Mrityu is mentioned. So the prognosis of the disease is not very good if we correlate with this particular. Now Nishwas, Uchwas, Sangrah, Pranavrit, Udana, Vyan, Stabdal, Pagnita, Sweda, Cheshta Hani is the feature here. Now coming to the management, thinking of the management of the disease, modern medical science has only one drug. So what we can see is that MND is a fatal disease with bad prognosis, owing to the involvement of all the three doshas predominantly. Vayu, Madhyam Rog Marg is affected, affection of the Marm Sthan is present. Avaran and the presence of life-threatening complications are present. So the majority of the management should be aimed to reduce the rate of the progression of the disease. If we are able to check the rate of the progression of the disease, then in itself, it is a very big achievement. Improve the symptoms of the patient, that is the second stage. First, if the progression is checked, that is a very big achievement. Now, the main stress which we can give upon is to improve the quality of life of that person. For example, if a person is dependent on two person, always dependent for small bits of action, daily routine activities, he's very clearly dependent on one or two people around him or his family members. So that in itself is a very depressing condition. So if we can change this or improve the quality of life, make him a bit more dependable on himself, more independent, then it would be a very big achievement. So aim of the treatment is to remove Avran of Kaph, normalize Vayu, Sotoshodhan, and maintain Agni and Bala. So generally, considering the Avran of Kaph, we can start the treatment from Rukshan and Deepan Pachan. So every treatment which we can start, it will depend, of course, it will depend on the person to person, it will vary, but we can generally, this is a safe side, to be on the safe side, we can start it from the Rukshan, Deepan and Pachan. Mridu Snigdha Virechan can be done. If possible, the patient can also undergo Virechan Karm if his physique and his bal and his strength allows. So Nasya can be performed to remove Kaph Avran and vitiate the features of the bulbar component of the disease. Acharya Charak has suggested Nasya Karm in Pranavrit Udan and Pranavrit Vyan. Vasti has to be the mainstay of the treatment protocol owing to its Vatshamak effect. Especially here, Yapan Vasti is can be indicated. Can be predominantly indicated because Yapan Vasti has a Rasayan property and it has been said to be Ayusho Yapanam, means it promotes longevity. So the most affected thing or the most dangerous thing which is targeted here is longevity. So Yapan Vasti should be used, and the Mas Balavardhan properties of Yapan Vasti, they can be adopted as per Charak owing to its role in Avaran Chikitsa. External therapies like Shashtikshali Pinswed, Abhyang, Mridu Swedan, they can also be employed. Shiropichu and Shirovasti, the Murni thalum, they can be used to good effect only to their Medhya effects. Now, this was my research work in during my post graduation at NIA Jaipur under the guidance of late Professor Radhesham Sharma sir. It was his vision to work on this disease as he was a Siddha Hasta Vaidya, and there were n number of patients coming to him in Jaipur. He was a wonderful clinician. So the topic of my research was a controlled clinical study to evaluate the efficacy of Nasya and Yapan Vasti in the management of motor neuron disease. And this was undertaken at the Ph.D. Department of Panchakarma, NIA Jaipur. The aim of the study was to evaluate the efficacy of Nasya and Yapan Vasti in the management of MD. Materials of methods. Now 30 patients were included, and they were distributed in two groups of 15 each. Group A, Nasya was done for 7 days alternately with Avartit Sheer Balatel, and this was followed by Mustadi Yapan Vasti for 30 days. And then 2 months of follow-up period was devised, and during that period, made the rasayan of Guduchi, Ayashti, Amalki, and Piplichun was administered to the patient. Abhyang with Dashmul Tel was and followed by Sarvang Sweden. This was advised during and after the Basti regime. In group B, what we did, Raluzole tablet, which is the only medicine available in modern system of medicine, it was advised to the patient to take it in 50 milligram for two times BD, that is. Now, objectives consisted of to evaluate the efficacy of Nasya Karma with Avartit Sheer Balatel, to evaluate the efficacy of Mustadi Yapan Vasti, and the third point is very important, to ascertain whether Nasya and Vasti could delay the progression of the disease. This was the most important objective. Inclusion and exclusion criteria as shown, and the patients in the final phase of the disease, that is those who are having respiratory distress, they were not included in the trial. And if any patient developed such symptoms, he was taken and discontinued, but it didn't happen, fortunately. So the assessment criteria, we use the MRC grading scale for the muscular power, and ALS functional rating scale, which evaluates speech, salivation, swallowing, handwriting, turning in bed, walking, climbing stairs, breathing, handling utensils, for example, a glass, dressing, and hygiene. Norris scale, these were this was used to judge the disease severity, and cough, grip, lift self, and labile emotions. Again, labile emotions is a very prominent feature, because if labile emotions are present, emotional lability is present, it is a sign of poor prognosis of the disease. A gradation for fasciculations was done because fasciculations are present generally in a particular dermatome. So the region of the dermatome was adjudged, and if more than two regions, like the cervical dermatome or the lumbar dermatome of the lumbar region, dermatome of the thoracic region, they were successively involved, the gradation was higher. This was a trial to evaluate the efficacy of both these procedures. And then normal functions of Vayu, like Utsav, Uchvas, Nishwas, Cheshta, Vek, Pravartan, these were hampered. Mans Dhatu was found to be the most vitiated. Now here, Gaurav, Shatyam, Lalas, Rao, drooling and salivation were also present, which are the Kapha symptoms. Shwas and Kas, these were found to be in clinical features in the patients with bulbar impairment. Now, in Avaranjanya Samprapti, coming to the drug used in the Nasya Karma, the Avartit Sheer Balatel, it was used because it is considered as a rasayan and having an action of Indiram Prasadanam. It is Swarre Shukrasik Doshanashanam. It is also, its action is related to opening of channels. Marga Sanshodhan Medso va Kafasya. Then it directly acts on the Vayu. Ati Vriddha Anile Shastadu Snehanam Brangana. And due to this reason, it was used. Mustadi Yapan Vasi, it has been said to be Ayusho Yapanam, Shukramas Balajanam, Sadhya Balajanam Rasayan. Due to the presence of Mansras, Gogret, and milk, it can act as a rasayan. It is specifically indicated in the Avaranjanya conditions. Now, demographic findings after the most of the patients were males. Most of the patients had mental and physical exertion, which might cause Vat Prakop. Then one of the Acharya Charak has mentioned the role of Gramya Ahar in manifesting of features like Masa Shaitilya, Asamartha Cheshta, and Ujakshaya. Now, these were the features which are actually present in people who consume lot of food outside, junk food or processed food. So they can, or the non-vegetarian food is also a part of this. So 90% of the here, what we saw is that 90%, since this study was in Rajasthan, most of the patients use tap water. 90% of the registered patients use tap water. There is a chance that lead poisoning has been postulated as among one of the etiologies of MND. Besides, mercury has also been postulated as one of the etiologies. Prakriti of the patients. Most of the patients, 46% of the patients were Vat Kapaj, 40% of the patients were Vat Pittaj. Most of the patients had a history of excessive consumption of milk and or dairy products, we can say, which could be a reason for Kapha Prakop. History of Ratri Jagran was present. Most of the patients were laborers. They worked, had mental and physical stress, and there were some students and doctors and people of marketing field. So there was a habit of Ratri Jagran in them. 36 patients were having a habit of Ratri Jagran. Out of the 30 patients, 9 patients had a recent history of Sanipata Jwar, and patient also pointed out that after getting cured from fever, after some time, the symptoms of motor neuron disease started. So this point should also be taken into consideration. Now, we have already discussed the types of MND. So, in this study also, we found that ALS was the most predominant form of motor neuron disease. Now, coming to the results and observations, effect on muscles of upper limbs. Most of the after Nasya, the mean value in the power of upper limbs was statistically insignificant. There was some improvement in muscles like flexor carpi radialis and adductor pollicis and extensor pollicis, which is known for extension of the thumb. So they showed slight improvement, but the changes brought about were not statistically significant. And the mean values after Vasti, this was in Vasti also mild improvement was seen in the power of muscles of upper limbs, but same thing was there, that the results were not statistically significant. Coming to the lower limbs, Nasya, it showed no significant changes in the lower limbs. However, the Yapan Vasti, there were the improvement in the power of muscles of lower limbs was seen. However, the change was again not statistically significant, but the change in power of muscles was there. Now, coming to the riluzole, there was no significant change produced by the use of riluzole in Group B patients. Effect on fasciculation. This was one of the clinical features in which we got the statistically significant results after Nasya, and the condition further improved after Basti. There was an overall improvement in fasciculation after riluzole usage also, but this was not statistically significant. Coming to the ALS functional rating scale, almost all the features, speech, salivation, swallowing, handwriting, every feature showed clinical improvement in most of the patients, but statistically they were not significant. Similar was the case was with walking. There was change after, especially after Vasti, the mean value improved, and there was this improvement in walking in most of the patients, but this was not also statistically significant. There was almost no change in effectiveness on breathing. Turning in bed, this was one of the clinical features again, which showed improvement significantly, statistically significant improvement after Basti completion. Now, coming to the Norris scale, most of the features here showed some improvement, very mild improvement, but none of the features were statistically significant. The symptoms present due to the compilation of the result can be done as the symptoms present due to the bulbar component of the motor neuron disease were the least affected during the trial in either of the groups. There was minimal change in the symptoms like dysarthria, fasciculations of the tongue atrophy, and dysphagia. And however, some further deterioration was also noticed in the upper motor neuron, especially in the bulbar component of the disease. Early diagnosed cases, which came with recent diagnosis without bulbar symptoms, they showed more improvement. The element features, the lower motor neuron features also showed relatively more improvement. The bedridden patients showed the least improvement, and the patients with pseudobulbar palsy, those who had the emotional lability and emotional incontinence, they were having the poorest prognosis. And in fact, after the completion of the trial, three patients were there who succumbed to their symptoms. And eventually they succumbed, they died. Unfortunately, the limitations of this study. Now, there were a lot of limitations of this study because we had to complete this particular study in an allotted period of time. So the sample size was not adequate. 15 patients in both the groups were taken. However, the prevalence of the disease is also not very big. The prevalence is less. However, I have seen that in arid areas of Rajasthan or in arid areas of Gujarat, this disease is relatively more prevalent as compared to rest of India. The treatment and follow-up time has to be more to draw meaningful conclusions. Inter-individual variability was more. Now, what is inter-individual variability? Some of the patients, they showed very good results. The improvement in muscular power and movement was good. But in some of the patients, there was no improvement. Again, in some of the patients, they came to us with minimal features and their disease deteriorated in some of the patients, they came with some of the features and they remained stagnant throughout. So there was a lot of inter-individual variability after the treatment was given. So multiple cycle of Shodhan, this is actually a recommendation which can be used in, which will also be given in the future study, for the future studies. Now there are some video clips which I want to show to all of you because it will help in understanding that although the results which we got, they were not statistically significant. They were not statistically significant, but the results we saw in some patients, the results were very good, especially for some time. And we can say that in some patients, we were able to check the progression of the disease. Rather, some patients showed very good improvement in the symptoms. However, later on, the disease overcame and the symptoms worsened. This is also a fact which I'll be showing you through these video clippings. This was a patient of marketing field.
नाम क्या है? इससे जोर से बोलिए, पूरा नाम बोलिए.
We can see the speech is affected. He has to make a lot more effort. He is not able to stand properly. When asked, he will stand with support. He has to take support from walker or something. He has to take support from two people actually. And this was the condition of the patient before the treatment. You can see in this particular video, you can see the distal muscles are affected, but proximal muscles, you can see this particular region, are still intact.
ये छोड़ दीजिए, आप खड़े हो जाइए, बस खड़े हो जाइए. आप एक हाथ पकड़ना, एक ही हाथ पकड़ना, ठीक है? बस बस, अब छोड़ दीजिए. अब चलने के लिए कोशिश करो, ट्राई करो ना. आप भी पकड़ो, हाथ पकड़ो.
He has to take support from two people. We can see this in this video. Look at his gait. Short pace steps, very close. Both feet are very close. He short steps he is taking. So that indicates that there's a deficit in the power of the distal muscles of lower limb.
बस
When after the treatment, and this is the before before the treatment, same day, he is able to walk only with the help of this particular walking.
मार्केटिंग जोर से बोलना मार्केटिंग
Now you can notice his speech also. He has to take extra effort to speak.
हमारे हेड सर किया पता है नाम बोलिए फिर से क्या काम करते हैं आप मार्केटिंग और जी
Their speech is not understandable. It is
मार्केटिंग कौन सी मार्केटिंग करते इंडस्ट्री
very. Now, after the treatment, after Nasen, Vasti, and Abhyan, we asked him to. He was able to walk without support. However, it was slow. However, it was very slow, but he was able to walk without any support, and this was a very beautiful achievement of the student. This particular disease, it only not only is a suffering for the patient, it is also suffering for the family members and everyone in the family suffers when someone suffers from this disease, because it is mentally very challenging and very depressing. Complete dependence on the patient is there. Now he is able to walk without any support.
आपको मालूम है कैसे करना है गैप्स बना के रखना है हाँ
Every now and then I have to.
एक फॉर्म पैर पड़े फिर दोबारा ही उसके बाद वैसे करना है ठीक है
Overall,
बहुत अच्छा वेरी गुड जल्दी नहीं है बिल्कुल जल्दी नहीं है रिलैक्स रहिए हाँ वेरी गुड वेरी गुड बहुत ही अच्छा
so now he was able to turn also without any support.
वेरी गुड घूम जाइए आ रहा हूँ
However, the speech was not. There was no improvement in speech.
आराम से बिल्कुल भी जल्दी नहीं है गैप बना के रखना है और एक पैर फॉर्म हो जाए फिर दूसरा पैर तब आगे बढ़ाना है ठीक है वेरी गुड बहुत अच्छे
Now, this was very satisfying to see that the
Very
patient was able to work without support.
yes.
Even this small pace test and this small
Good.
thing which we achieved was really very satisfying.
Very good.
Now, coming to another patient, he came to our hospital and we had the videos of after the treatment. He showed some very good improvement and he's testifying to his improvement. Earlier he was also not able to walk. He used to walk with support from two people. Now he was able to walk after the treatment.
मोड़ नेक पे जाने टर्न को
You can see he is able to turn. He himself will tell that what happened earlier. He'll tell in this clip.
बस ये हाथ उठाना पूरे ऊपर एक एक करके
You can see how happy he was, how satisfying he was. He was a milkman by profession. He was had a history
आप ना एक बार बोलना इससे पहले आप कैसे आए थे बोलिए इससे पहले मेरी आवाज बंद हो चुकी थी मैं चलते चलते कैसे जाता था कपड़े नहीं पहन पाता था खाना नहीं खा पाता था आवाज बिल्कुल बंद हो चुकी थी यहाँ सिरिक होके कितने महीने हो गए यहाँ 2 महीने हो गए 2 महीने मेरे 40% फायदा है बिल्कुल पहले आवाज समझ में नहीं आती थी मैं क्या बोल रहा हूँ अब बाथरूम में बैठा नहीं जाता था अब आराम से बाथरूम में बैठ जाता हूँ उठ जाता हूँ खाना भी खा लेता हूँ आप जब भी यहाँ ट्रीटमेंट के लिए आए थे आप अकेले आए हो नहीं कोई साथ आए थे मेरे 2 साथ आए थे अब मैं अकेले रहता हूँ तो आप अकेले चल पाते थे हाँ नहीं पहले नहीं चल पाता था अब चल पाता हूँ अब आपको कैसा लग रहा है अब बहुत अच्छा लगा जैसे नई जिंदगी मिल रही हो क्या क्या काम कर पा रहे हैं अभी मैं खाना खा लेता हूँ अंडरवेयर पहन लेता हूँ कपड़े पहन लेता हूँ कर लेता हूँ सब अपने आप कर नाम शुरू मेरा नाम गिरिराज चौधरी है मैं 2007 से बीमार हूँ पहले यह दाम हो गया था कैसे शुरू हुआ मोटरसाइकिल से गिर गया था मैं ये हाथ कमजोर हो गया कितने दिनों बाद हुआ ये हाथ ये धीरे हुआ गिरने के 2 महीने बाद 2 महीने बाद अच्छा आप बोलिए फिर ये पैर धीरे धीरे डाउन हो गया फिर ये हाथ हो गया
You can still say there is some weakness in the distal muscles, in the hands, in the speech is still not very clear. But as compared to earlier, he's testifying to that.
जैसे जैसे चलता था तो फिर जाता था आवाज बिल्कुल बंद हो गई आराम से ऊपर ये वो बाद में क्या हुआ यहाँ मेरे को बच हुआ यहाँ मेरे को 2 महीने हो गए कौन लाया आपको मेरे को 2
Next, after the completion of the trial and the follow-up, he was in touch for some days. But I had to, after 7 or 8 weeks, we had been in communication, in contact, and he informed me that the picture was not very good. The clinical features have worsened, and the disease has progressed to a new level. So I went to his house, and we saw what actually happened. The speech has deteriorated. You can clearly hear the dripping, the feeding, everything has deteriorated because of the progression of the disease.
लेकिन पहले से आपका थोड़ा वजन बढ़ा है
मैं करवाया तो वजन बढ़ा
और कोई चीज है जो फर्क हुई है वहां से अभी तक आने में यहाँ
He is not able to stand on his own. He has to take support from
अभी घूमते उठ पाते हैं आप अभी खुद से उठ पाते हैं, सपोर्ट से उठ पाते हैं, उठ के दिखाइए एक बार, सपोर्ट दीजिए। वेरी गुड। अभी चल के जाना है, बिना सपोर्ट के चल भी नहीं पाते।
No, he's not able to walk actually without support. So he has to take support of us. And this was the picture after 8 months of the completion file. You can see how the disease has progressed even more severely. So the happiness and the satisfaction which he and we both got, it did not last very long. The disease and the progression of the disease, it overcame.
बिना सपोर्ट के खड़े हो पाते हैं, सपोर्ट के बिना खड़े भी नहीं हो पाते। अगर ये छोड़ देंगे तो क्या होगा? गिर जाएंगे। घूम जाइए, घूम जाइए। ठीक है, घूम सकते हैं खुद से। खुद से घूम सकते हैं आप। ठीक है, इनको एक बार घुमा दीजिए।
Now coming to the second patient, Naval Mishra, he was also not, he also showed some good signs. He also showed improvement. His gait was improved, the strength was improved. But after some time, the disease progression worsened and it overcame. So I had an opportunity to visit him, and then we saw the features were not very good. It was not very convincing. Here also we can see that there's a loss of muscle strength. The whole of the muscles has weakened. The movements are not very good now. Stiffness is there. Speech has also deteriorated.
बोलिए अपना।
He is not able to speak even. You can see how much force he has to take to speak his name out.
देख के बैठ पाएंगे?
For small things, he had to take support of his wife, and the picture really turned upside down, and it was not a very pleasant thing to watch.
खड़े नहीं हो पाते ना, सपोर्ट लेना ही पड़ेगा। बैठ के उठने में भी तो प्रॉब्लम है। भी खड़े हो पाएंगे?
The gait is also hampered. Everything has deteriorated. Not very confident, not very happy in taking a step ahead for moving or walking. Just
नाम बताइए अपना। जोर से बोलिए। अभी क्या क्या दिक्कत है आपको?
he is not able to eat, swallow food. Severe dysphagia.
खाना नहीं निकल पाता। और अच्छा
See how much effort he
पानी
has
नाक से तो नहीं निकलता अभी
make to utter a single word. In this patient, we can also see some emotional ability. He is definitely he is not in a very good shape, but there is a smile over his face.
सपोर्ट चाहिए होता है अभी उठाने के लिए किसी का, दो लोगों का या एक लोग.
This is emotional ability in him. So this was the picture after follow-up in these patients. Now, there are certain recommendations for the future studies. Now, the future studies must be conducted on a single variant because what we did, we took MND as a whole. Although in the future studies, it would be better to consider ALS or any one form, and it should be done on a single variant, and larger samples should be the study should be conducted on the larger samples so that the conclusions could be a bit more concrete. Longer periods of study and follow-up to deduce better conclusions. Public awareness should be created for early detection and better management. There is a need for educating people about this disease and about their prakriti and suitable ahar vihar for disease prevention. For example, if a person is having Vatash Prakriti or Kapha Vatash Prakriti, so then he should be guided accordingly. Then other thing is that which for which the people should be educated is that Ritukalik Sanshodhan should be promoted and propagated in the patients. Seasonal detoxification needs to be promoted because in this era of food, water and air contamination, Panchakarma provides a very good option of cleansing or detoxification. Effective implementation of palliative care should be there. Shashtik Shali Pinsway, Shiropichu, Shirovasti food should also be incorporated along with the Virechan, Nasya and Yapanvasti. Now, Vaman is also an option, but Vaman can not be performed in such patients because there are certain patients who had bulbar palsy, so it would be a difficult option to select. So, in general, Vaman is generally not advisable for patients with bulbar and pseudobulbar palsy. Now, Virechan, Nasya and Yapanvasti can be undertaken. Incorporation of multiple regimes of Panchakarma therapy and Rasayan therapies should yield better results in future. Now, if the duration of the trial is longer, then after single Panchakarma therapy, a Rasayan therapy should be then, and then following the Dviparihar Kal, and then we can again start the Panchakarma therapy with Yapanvasti, or then the Rasayan therapy should be administered. So this should be done in a cyclic manner to produce maximum benefits. Then suitable Rasaushadhis or gold preparations accordingly, they can be used as an option for a shaman drug in between the cycles of Samshodhan. Now, besides this, what was one particular positive thing which came out, that there were several patients in which there was improvement, which we can see in these video clips. The improvement was definitely for some time only, and that was for a limited time only. But they have been there should have been some changes in the molecular level or the tissue level or the cellular level. So we need to advocate and promote those changes which we are bringing, because if we are doing a slight improvement in the condition, if we are checking the progression of the disease for a limited time only, then also we need to convey the message very loudly and very clearly that and if that is supported with molecular or cellular studies or fine studies, then that would make a much more impact if we just communicate on a scientific, want to communicate at a global level or at a scientific level. So that should be there. Active, passive, and besides that, we have also conducted some studies on stroke with Institute of Genomics and Integrative Biology, a collaborative study, and with this vision only, under the guidance of Dr. Bhavna Prashram. Active, passive exercises, physiotherapy, and speech therapy should also be incorporated along with for better results. Thank you. I'd like to deeply acknowledge late Professor Radheshyam Sharma sir for his inspiring vision and guidance. It was his vision to work on this dreadful disease, and but he unfortunately he's not presently among us. So I humbly pay my gratitude to all the brave patients fighting this dreadful condition, wishing them health and longevity because they are going through a lot. I'd like to also acknowledge and give my thanks to my guide, Professor Ajay Sharma sir, and all the teachers, Bhattar sir, my teachers and my seniors at NIA who were a very strong support at that time, because not only this condition, this disease, this work was physically draining, but it was also emotionally very draining because the condition of the patients was very challenging. They were suffering, but all of us were keeping a watch on that. Was also emotionally very challenging. So I thank all of them for their support. I thank Rajkala ma'am for this wonderful platform, for this wonderful opportunity which she has provided to me today. And she has always been a wonderful teacher with a beautiful heart. And the time which I have spent with her has always been a great learning experience for me. And thank you, ma'am. Thanks a lot. Thanks to all of you. Thank you, Dr. Pawan, for your cooperation. Thank you, Dr. Karishma, for your cooperation. And thank you to all of you for your patient listening. And thanks a lot.
Thank you, Dr. Adil, for such a amazing and knowledgeable and wonderful lecture on MND. Of course, your efforts will help all of us, or all the Dr. Panchakarma fraternity who will work in the MND. And you have rightly elaborated the Ayurvedic perspective and the Panchakarma modifications which you have to do, and the clinical cases which you shared with us. Thank you for that. And the follow-up, this shows your dedication for the Panchakarma and for the patients. Okay, so thank you for sharing all the data with all of us. And of course, that will be very useful for our students also and the practitioners who have joined online. And on behalf of Department of Panchakarma, I thank you for giving your valuable time for us for this session. And of course, thank you, Dr. Karishma, also for introducing and giving time for us to introduce Dr. Adil. Okay.
Thank you so much. Thanks so much.
Yeah.
Thanks a lot.
Now, if anybody is having any questions, they can unmute or they can raise their hand. So we can unmute them and they can ask the question to Dr. Adil.
Thank you, sir. Is it advisable to stop riluzole? Actually, this is the only drug which is being used by in the modern system of medicine. But the thing is that we conducted this study and none of the patients were given riluzole. So from the Ayurvedic perspective, we can say that we won't be using riluzole because it produces no significant effect, because the effect which should have been produced is over the quality of life. The quality of life is still, it deteriorated. The only thing was that on using for 5 years, the lifespan means expanded to by 180 days. So definitely we can stop riluzole because none of the patients in my trial were given riluzole. Earlier they have been taken. Earlier when they were definitely they were diagnosed by the modern practitioners in the modern hospitals. So they were advised riluzole for taking it. Which lakshan we should consider to stop rukshan and start snehan in a MND patient? When the niram avastha is there, then we can stop the rukshan and we can start snehan. That is a very simple thing. We have to monitor the case every day. When if at all there are symptoms of arm, if at all there are symptoms of heaviness, alas, gaurav, all these things if present, we can stop the rukshan and then we can start the sneha. Any other vasti we can use? Yes, baladi apan vasti can be used. Majja sneh can be used. There are certain other options depending on the. We selected mustadi apan vasti because it is a broad spectrum vasti. It covers multiple aspects of the disease. So that was a better option as per my knowledge. Whether no, Matra Vasti was not done in between. All the 30 Vastis were given on a stretch. Is it advisable to do Swedan in these patients? Yes, Swedan can be done, but you have to consider certain aspects. You have to consider the temperature. You have to consider the climate. You have to move according to Prakriti of the patient. And the timing of the Swedan can vary. And Swedan, it is always acting as a Srotoshodhan. It has Srotoshodhan effect. So that will enhance your the effect of your drug action. Can we do Shodhan Nasya initially in these patients? Yes, it is a very good option. We can do Shodhan Nasya. If the Kapha Pradurbhav is more, we can do Shodhan Nasya. And after that, when we see the Kapha Pradurbhav is less, then we can use the Bringan medicine. That is definitely that can be done. We have to assess the patient because this is a condition in which personal assessment of the case is very important. Day by day monitoring, everything has to be considered. That is very important. Use of Rasikalpas along with continuous. Yes, it depends on the doctor or the physician who is treating the case. Rasikalpas like Yogendra Ras or Britva Chintamani Ras, they can be used. We had a different intention. We had to show the aspect of Panchakarma. So in this trial, we were not using any Raskalpa here. But in general practice, it should be used. If spinal cord injury is affecting the neurons, then how it causes sensory loss? As you said, it is not sensory affected. Sensory is never affected. Spinal, if at all the sensory portion component is involved, it will not be a motor neuron disease. It will be a different disease. The diagnosis will change. Any other questions or any other doubts which we can discuss here?
No, Dr. Adil. I think now everything is clear for all the neurological disorders. I think in this session, last session was on Parkinsonism, and this session is on MND. So we have covered the neurology and Panchakarma. Okay, so it was very clear presentation. Everybody understand that of course if there is sensory involvement, that will not be the MND. Okay, so you have cleared all with the clinical data. Thank you so much. And of course, I know you are a very hard worker student and hard work, very sincere clinician also. So all the best for your future, and thank you for joining today.
Thank you so much, ma'am. Thank you for this wonderful opportunity, and thank you for your beautiful words. Thank you, ma'am.
Thank you all for joining and make evidence-based Panchakarma guest lecture series a successful event for this BHU. Thank you all.
Thank you, ma'am.